Checkpoint inhibitors are being evaluated quite extensively in every type of human malignancy, largely based on the stellar successes they have had in many different types of solid tumors like melanoma, lung cancer, bladder cancer, renal cancer, as well as in heme malignancies, specifically Hodgkin's lymphoma, and also in some other forms of lymphomas and myelomas in combinations. We have been one of the first groups to do a lot of clinical research as well as translational work with different immune checkpoint-based therapies in acute myeloid leukemia. At this time, what I will say is that there does seem to be some encouraging activity with these checkpoint inhibitors, especially with the PD-1 inhibitors in AML in the relapse setting. However, there is no clear blockbuster efficacy, and I think it is going to take more biomarker-driven strategies as well as better awareness and management of toxicities to get this to a point where it could be either approved or used routinely in acute myeloid leukemia. So we have a number of studies ongoing. The one that's probably the most mature is the combination of azacitidine with PD-1 inhibitor nivolumab. We published this data in the journal Cancer Discovery about a year ago. This was all relapse refractory patients. We treated a total of 70 patients. The overall response rate was about 35% in these 70 patients with a median of 2 salvages. In general, this response rate is better than the historical published response rates with single-agent azacitidine or decitabine in a similar salvage population. This was published by Dr. Zaidan and colleagues in about 600 plus patients, where the overall response rate was about 18 to 20%. So 35% was better. But really, what is encouraging was the survival that we saw in the early salvage patients with the azacitidine and nivolumab. And we see in salvage 1 patients, which were about half, 35 out of the 70 patients, the median overall survival in relapsed median salvage to predominantly older AML was about 10.5 months. This is actually very nice and better than the expected median salvage in a similar population with HMA alone, which is about 6 to 7 months. Now, this is a single center study, and it's hard to know for sure if this would translate. But we do think, based on additional translational and correlative analysis that we have done using flow cytometry as well as CyTOF on pre-treatment as well as on-treatment bone marrows, that the baseline T-cell infiltration in the bone marrow is a very good predictor of who will respond to the checkpoint inhibitor-based treatments, as well as who will have a very durable response. And in general, we see that those patients who have more T-cells, whether it's total CD3 T-cells or the specific CD8 cytotoxic T-cell infiltration to begin with, are the ones where it's easier to harness the immune system with a PD-1 inhibitor, get a good response and a durable response. Even when we look at it functionally using a very nice technology called isoplexis, which looks at single cell 32 cytokine profile, we can clearly see that those patients who have a more diverse and a quantitatively higher cytokine profile at baseline are the ones who seem to respond very nicely when we add in the immune enhancing PD-1 versus those who have a very blunt or immune desert kind of T-cell cytokine profile are not responding. So I think the field is now starting to think more and more about biomarker driven, applying these in early salvage in patients with low blast burden, where you also will have more T-cell infiltration. And I think there could be a nice niche indication. The other study that we're doing, building on the azacitidine nivolumab that was published, is a triple combination of azacitidine with PD-1 inhibitor nivolumab with CTLA-4 inhibitor Ipilimumab. And the rationale for this comes from a lot of solid tumor data showing that the combination of PD-1 CTLA-4 is highly effective. And we also saw in analysis on our treatment samples on azacitidine and nivolumab that the CTLA-4 pathway was significantly upregulated, especially in the non-responders, suggesting it could be the escape mechanism. This study is showing better response. The CR/CRi rate is about 45%, so improving on the 30-35% with azacitidine nivolumab. And especially in people with extramedullary disease, there seems to be a very nice signal. 4 of our patients who had skin, lymph node, liver type of extramedullary leukemia responded and have maintained the response anywhere from 3 months to 14 months. So there may be a nice angle for this extramedullary leukemia, which was first shown by the group at Dana-Farber using Ipilimumab post-transplant in extramedullary disease, where they also saw some very nice activity. Now, the last thing that we're seeing is that it may not be PD-1 CTLA-4 alone that is the ideal checkpoint for AML, and why that is not too surprising. In general, the mutations that we target in AML, like FLT3, IDH1, IDH2, are also not common or not the usual ones in solid tumor. So there may be specific discrete immune pathways, and one of those that seems to be really important is the CD47. Now, this is a immune checkpoint, but unlike PD-1, CTLA-4, that are T cell immune checkpoints, removing the brakes on T cell, CD47 inhibition removes the brakes on macrophages. So very elegant work done by Dr. Majeti and Wiseman over the last 8 to 10 years, showing that this pathway was very important and maybe specific for AML as well as lymphoma, has led to clinical trials that are being done by Dr. David Salmon at Moffitt and me, along with a number of other centers, where we are seeing in frontline MDS response rates of about 85 to 90%, which is something we have never seen before. The responses seem to be very, very durable, and the therapy is very safe, with the exception of some early anemia, which is expected because CD47 is expressed on the red cells. So we think this could be a nice, effective, and potential specific checkpoint in MDS, also showing very nice early activity in TP53 mutated AML, where response rates that were shown at ASH this year were about 70% CR/CRI, and they seem to be very, very durable. So look forward to updates of this CD47 immune checkpoint for macrophages that will be coming at the EHA and the ASCO meetings this year. And with that, I would like to stop and thank you very much.